हेलो फ्रेंड्स, आज हम बात करेंगे हाउ विल अप्रोच टू अ न्यूबॉर्न हु इज बॉर्न टू अ मदर हु इज SLE, that is approach to a baby of SLE positive mother. We'll find out कि what are the chances of baby getting neonatal lupus erythematosus. सबसे पहले क्या होता है, what happens कि बच्चे को neonatal lupus erythematosus क्यों होता है? क्योंकि जो SLE positive mother है, in case if she is positive for auto antibodies, SSA, that is Sjogren syndrome autoantibody type A, that is called anti-Rho, or SSA type 2, type B, which is anti-La. अगर मदर एंटी-रो और एंटी-ला एंटीबॉडीज पॉजिटिव हैं और ये एंटीबॉडीज जो हैं वो पैसिवली बेबी को ट्रांसफर हो जाती हैं, तो देयर इज अ रिस्क ऑफ बेबी गेटिंग न्यूनेटल ल्यूपस एरिथेमेटोसिस. देयर इज अनदर टाइप ऑफ एंटीबॉडी दैट इज कॉल्ड एज U1 ribonucleoprotein antibodies along with these two antibodies, but this is one is comparatively less common, right? अब क्या होता है कि कितना अगर मदर को ये दो एंटीजन पॉजिटिव है तो कितना इंसिडेंस हो सकता है न्यूबॉर्न में ल्यूपस एरिथेमेटोसिस होने का. देयर इज अ 2% इंसिडेंस इन द बेबीज हु आर बोर्न to SLE positive mothers with these anti-Rho anti-La antibodies positive to have the lupus erythematosus. और subsequent pregnancies में कितना रिस्क रहता है? 18 to 20% recurrence in the subsequent pregnancies. अब हम बात करेंगे कि regarding the manifestations of your lupus erythematosus, राइट? सो बेबी अगर SLE पॉजिटिव मदर का है तो हमें ये चीज़ें ध्यान में रखनी है. मदर की हिस्ट्री पूछनी है कि मदर को कौन कौन सी एंटीबॉडीज जो हैं वो करवा के रखी हैं, what is the history of drug that she has taken, and we must also know the spectrum of the signs and symptoms. Basically, what is the spectrum of the clinical manifestation, how SLE can affect the baby, right? तो हमने सबसे पहले बात करनी है द मोस्ट कॉमन प्रेजेंटेशन इज योर क्यूटेनियस मैनिफेस्टेशन, जिसमें रैश होता है. इरिथेमेटस रैश हो सकता है, ट्रॉफिक रैश हो सकता है. द सेकेंड मोस्ट कॉमन मैनिफेस्टेशन इज योर कार्डिक, जिसमें सबसे कॉमन प्रेजेंटेशन जो होती है बेसिकली रिदम एबनॉर्मेलिटीज होती हैं, जिसमें यू कैन हैव AV ब्लॉक्स. देन यू कैन हैव सिस्टमिक मैनिफेस्टेशंस एंड प्राइमरीली हेपेटोबिलियरी सिस्टम इज इन्वॉल्व, जिसमें आपको अमाइनो ट्रांसफरेसिस के लेवल ज़्यादा हो सकते हैं. अलॉन्ग विद दैट यू कैन हैव एलिवेटेड बिलिरुबिन, एंड देन यू कैन हैव हेमेटोलॉजिकल abnormalities. Then you can have CNS abnormalities. In CNS you can have seizures. In hematological there is decrease in all the three cell lines, the HB, the leukocytes and the platelets. All the three cell lines are in decreasing trend. Discuss the pathophysiology of neonatal lupus erythematosus. We have anti-Rho, we have anti-La, and we have U1 ribonucleoprotein antibodies, which are the most common. Anti-Rho is your SSA type A, it is SSA type B, and then this one. This one is with molecular weight of 52 and 60 kg, right? And this one La is with the molecular weight of 50. Now what happens? The one with the molecular weight of 52 anti-Rho antibodies, what it does basically, there are L-type calcium channels which are present in the fetal heart. Okay, you have fetal heart. There are serotonin induced L-type calcium channels which are present in the atrium of the fetus. So ये anti-Rho antibodies क्या करती हैं कि इस जो कैल्शियम चैनल्स होते हैं इनके साथ बाइंड अप कर लेती है, इनको एंटागोनाइज करती है. एज अ रिजल्ट ऑफ दिस इट इनिशिएट्स इन्फ्लेमेशन एंड फाइब्रोसिस इन द मसल्स ऑफ द एट्रियम. दैट कैन फर्दर लीड टू स्कारिंग ऑफ AV node, SA node एंड बंडल ऑफ हिस, जिसकी वजह से प्राइमरीली रिदम एबनॉर्मेलिटीज होती हैं और कार्डिक आउटपुट जो है वो कम हो जाता है. दैट कैन फर्दर लीड टू CH, राइट. ऑल्सो anti-Rho antibodies, they bind with your neutrophils, thereby causing decreased neutrophil count, that is your neutropenia, right, thereby causing neutropenia. Now there is also another thing, that which type of autoantibodies are positive. It has specific association with the type of clinical manifestations. Supposingly you have 52 and 60 kD anti-Rho antibodies, right, this one. And for La antibodies, if it is 48 kD that is La antibodies, these sets they have more association with the heart blocks. लेकिन अगर 50 kD वाला 50 kD La antibodies is there, so there will be more of the skin manifestations, like बच्चे को rash होगा, right, cutaneous manifestations will be there. For those with the you have U1 ribonucleoprotein antibodies positive, they can have atypical manifestations. They can have atypical manifestations with the thrombocytopenia. Atypical manifestation with thrombocytopenia, right? These are the manifestations. So, अगर mother is SLE positive, it can either lead to spontaneous abortion, right? If controlled, it can lead to stillbirths भी हो सकती हैं. Then there can be IUGR or low birth weight babies, and then you can have your preterm deliveries. The babies who are born to SLE positive mothers, they have a typical eye appearance. Typical eye, that is called as owl eye. Owl eye, also called as raccoon eye. Okay, that is, you have got raccoon eye. And what is this called? This is basically periorbital erythema. This is periorbital erythema. Okay. On exposure to heat or sun exposure, any sort of heat, sun exposure will precipitate eruption of rash. The rash is photosensitive. There is likely chance that the baby who is born to a mother may be normal at birth, may have no cutaneous lesions, but can develop the rash within the first week of life. Within first week of life, the baby can develop the rash. So if the baby is born to SLE positive mothers, one thing is that we have to look for the clinical features. The one is your cutaneous lesions. You have to look for the size of the head, that is macrocephaly, which can be due to hydrocephalus, right? Then the second is where you can have asymptomatic hepatosplenomegaly, right? You can have blocks. You can have rhythm abnormalities. So what all set of investigations you are supposed to get? You have to get the CBC investigations, CBC, because in order to see whether all the 3 cell lines are decreased or not. Then you have to get the USG cranium, because SLE can have CNS manifestations which can manifest in the form of seizures also, right? Then you have to get the USG abdomen, because there is asymptomatic hepatosplenomegaly. Because of there is rise in bilirubin, there is associated your bilirubin is high, aminotransferases. You have to get the LFTs done, you have to get the RFTs done, right? And urine analysis also have to be done. right? Then you have to see कि what अगर mother जो है, mother is you have to evaluate the history of mother as well. Usually mother में क्या होता है, mother is screened for anti-Ro, anti-La antibodies, right? Anti-double-stranded DNA antibodies, anti-nucleoprotein antibodies, ANA is there, and anti-U1 ribonucleoproteins, which are the most commonly done, right? Antenatally, you have to see for the titers also. If this is positive, you have to see for the titers. And if the titer is antenatally, the titer is more than equivalent to 50 units per ml, the risk of baby having NLE, that is Neonatal Lupus Erythematous. So there are guidelines कि अगर mother is SLE positive, serial echos are done. Serial antenatal echos of the fetus are done from 18 to 24 weeks to detect early AV blocks, right? To detect early AV blocks. Then what is it? Mortality. Mortality in those with the neonatal lupus erythematosus is because of what? Is because of AV blocks, right? If AV block is there, then congestive heart failure can be there, and that can lead to death. So there is high mortality. What happens in most of the cases, the symptoms, be it the cutaneous manifestations, you have to, or be it the systemic manifestations, or be it your hematological manifestations, right? What you have to do, you have to give the supportive treatment, right? You have to give the supportive treatment. Cutaneous lesions usually settles on its own, but in some of the cases, atrophic changes and telangiectasias can be seen. Mostly treatment is not required. Spontaneous resolution is expected to occur between 2 to 6 months of age, and moreover, in some of the cases, not later than 1 year of age. But those who are born to SLE positive mother, you have to keep the babies under regular follow-up to find out, because they have high chances of getting any type of connective tissue disorders. They have to be kept under proper follow-up till adolescence, right? Till adolescence. As we talked, कि cutaneous lesions जो हैं, they heal without scarring, right? Most of the lesions, they heal without scarring, and in some of the cases we can have atrophic changes and we can have telangiectasia. We have to just give the supportive care. Now what happens, the mother, in mother we will do the serial echo, right, from 18 to 24 weeks to early predict the AV blocks, and mother is also given IVIG antenatally along with the steroids, okay, to prevent cardiac manifestations, of SLE, right? But again, even if it is given, it has no role in third degree AV block. It will be of some help in first degree or second degree AV block, but it will be of no help in case of your third degree AV blocks. In some of the cases, we can also give antimalarials, hydroxychloroquine, for those with the anti-Ro antibodies positive SLE mothers, okay, in order to decrease the manifestations in neonates. So in case if there is bleeding in the neonate because of decreased platelet count, so you have to give the platelets, right? You have to give the platelets. You have to give the supportive care. Or everything is just supportive. Spontaneous resolution, it is self-limiting, usually resolves within 2 to 6 months of age and not later than 1 year of age. There is another thing, that 25 hydroxy vitamin D levels is inversely proportional to SLE activity, right? It is inversely proportional to So if it is less, the SLE activity will be more, right? So you have to see for vitamin D levels in these babies also, right? Those who are born to SLE positive mother.